Welcome everyone back to Plum Peeps. Furf and I have been on a roll with doing one of our favorite episodes, which is our Fellows Case Files. And really excited about this one today. Furf, how are you feeling?
Good. Yeah, this is like my favorite. I feel like we've been getting a lot of emails with great cases from people who are really interested. So keep them coming. We love to hear about them. And then we hear a lot of feedback afterwards about people learning something and bringing it to their next case. I'm really excited about this one. We're going to Mount Sinai Morningside West, and this hospital has a very special place in my heart. I used to live right across the street. I did work for a year before med school at the Ryan Chelsea Clinton Community Health Center doing some HIV services work, and Sara Luby, who's joining us today, that's where she does her longitudinal clinic. So near and dear to my heart. The Olympic Flame Diner probably had way too many meals there that I'm sure sounds familiar to everybody. So I'm really excited to dive in, meet our guests, and to hear about this case.
Awesome, Furf. And I think I already have a learning point. I didn't know that you did that before med school. So that's cool.
Yeah, I loved it.
Thanks for sharing. So excited today, though. To first, we're going to introduce Dr. Sara Luby, who's a third-year internal medicine resident, and amazing is going to be a rising chief resident for next year at Mount Sinai Morningside West, and she's also planning on applying to Pulmonary Critical Care Fellowship this upcoming year. So excited to have you on the show, and welcome to Plum Peep, Sara.
Thank you for having me.
Yeah, absolutely. Thanks for reaching out to us with this great case. Next, we have Dr. Javier Zulueta. Javier is the chief of the Division of Pulmonary Critical Care and Sleep Medicine at Mount Sinai Morningside West. He completed his residency training at St. Luke's Medical Center and Case Western in Cleveland, and his fellowship in pulmonary critical care at Tufts Medical Center in Boston. And we were just talking how he's coming back here for chest. We'll have to meet up when you do. His research focuses on lung cancer screening and incidental lung nodules and findings. Thanks for coming on the show.
Thank you for having us.
Thank you so much, Javier. And last but not least, we have Dr. Mirna Mohanraj, who's the Associate Program Director for the Pulmonary and Critical Care Fellowship at Mount Sinai Morningside West, Beth Israel, and is also an Associate Professor of Medicine and Medical Education at the Icahn School of Medicine in Mount Sinai. Mirna completed her residency training at the University of Chicago and her fellowship training at Mount Sinai Hospital. And such a pleasure to have you on, an honor to have you on the show today, Mirna. Thank you for joining us.
No, thank you. So excited to be here.
Great. So before we dive in, our standard disclaimer, as a reminder, this podcast is not meant for specific medical advice and is for education. The views we express today may not reflect those opinions or policies of our respective employers. And the case we're presenting today is HIPAA compliant, and some details may have been changed to protect the privacy of our patient. So with that, let's dive in. Sara, it sounds like you had a really interesting case that you encountered on the pulmonary consult service. Why don't you tell us about how this patient came in?
Yes. Okay, so we had a 51-year-old male. He has a history of hypertension, AFib, status post ablations ×2, non-ischemic cardiomyopathy, VFib arrest. He had an ICD placed, and he was presenting with acute on chronic chest pain and shortness of breath. And he was describing the shortness of breath as non-exertional, intermittent, and was associated with pleuritic chest pain, which he described as a pulling sensation. And over the 2 days prior to his arrival, he had been having worsening chest pains, and the shortness of breath and dyspnea on exertion had also worsened. As an outpatient, he was being worked up for a pre-op clearance for a back surgery, and they had done a chest x-ray, and that found a new left-sided opacity. And given his chest pain, shortness of breath, and the new opacity, his team sent him to the emergency room for further workup.
Thanks so much for sharing that, Sara. And I know a little bit of a brief history, but you had some really great information there. And for those listening today, taking this as a problem representation, I would briefly say we have a 51-year-old male with significant cardiac history with acute on chronic chest pain and dyspnea found to have an incidental left lung opacity. And I think all of us today are thinking, we commonly see this, right? Chest pain and dyspnea are common presenting symptoms that our ED colleagues see, IM, as well as PCCM providers encounter. And I know there are many schemas available to help compartmentalize etiologies, but I think the five of us today are like, we want to make sure that we're thinking of all the emergent and can't miss diagnosis. I think a quick review, the top five, I think with both chest pain and dyspnea that we're thinking about could include acute coronary syndrome, or ACS, aortic dissection, cardiac tamponade, and then from a more pulmonary vascular component, PE, and then a pneumothorax. right? So I think those are going to be can't miss diagnosis. Something slightly different. You said that he's presenting with more of acute on chronic. So it makes me think slightly less that those are occurring, but things that we definitely want to rule out. I think some other things that probably we're all thinking on a differential right now under the cardiac bucket could still be an ischemic supply demand. Given his significant cardiac history, we have to be mindful of that. Something else that could be related is we always think if someone has severe anemia, could he have this supply demand mismatch that we're thinking of? So obviously, we'll be interested in checking his CBC. Other things can include pericardial involvement, so pericarditis or constriction, as well as the myocardium itself or the muscle. So a myocarditis and or stress cardiomyopathy are two things that think about as well. From a pulmonary aspect, other things I would add could be a pleuritis or a pleural effusion. But given the chest x-ray that you mentioned, it doesn't seem like that is the case, but would definitely want to rule that out and evaluate him on exam. I mentioned from a vascular component PE. I think other probably less common presentations, but something that we may still have on our differential can include more of a musculoskeletal component, such as or something involving lupus pleuritis or RA with pulmonary manifestations. I know that Furf and I have seen this commonly present as well. So those are what I'm thinking of right now based on the brief history, but you provided some great information. But for anything else that you want to add or that you're thinking about that we listeners should be aware of?
No, I love it. I think I do similar buckets like that, can't miss, and then like an anatomical approach to
Mhm.
cardiac, pulmonary, musculoskeletal, and working through the different aspects of it. Features of the chest pain are obviously always really helpful. This is like non-exertional, it's pleuritic, it sounds less cardiac. You can get atypical presentations. The pulling sensation is pretty unusual, right, to hear for a pulmonary process. Makes me think whether one, it could be musculoskeletal related to his back problems, whether or not he could have had other surgeries. There's like scar tissue in the area, or maybe something like pleural and anatomic, because as we know, the lung doesn't have pain receptors itself, and that would be a very unusual sensation. I feel like a lot of times I have patients who say their pain is right in their lung. And so I wonder with a patient like this, he has an opacity, has this acute on chronic chest pain and dyspnea, probably related, but the pain can't be explained just by a lot like intrapulmonary opacity, right? So we always have to be thinking of something else that's going on, given that we don't have that sort of pain and receptors or innervation within the lung. So I think we have a good framework to go forward. Sara, can you tell us a little bit more about what the patient looked like when it got here and some additional testing and history?
Yes. When he first came in, he was hypertensive to 143 over 100, but further in the day had improved to 121 over 81. And then the rest of his vitals were normal. He was saturating well on room air and was afebrile. In terms of his exam, was largely unremarkable for us as well. He had no chest wall tenderness, his heart was regular, and his lungs were clear. Most of that was normal. And then in the ED, they also got a chest X-ray, and the chest X-ray and the ER showed an extensive oblong opacity to the left upper lobe, and it showed a hazy density lateral to the lower left cardiac border, and it was suggested that it could be like a lingular opacity or an unusual fat pad that was not present in previous images. But the radiologist had noted that they would recommend a chest CT to further define what was going on.
Awesome. Thanks so much, Sarah. I think appropriately so, the pulmonary consult team will often get consults like this to add our opinions and recommendations. And again, from what you were saying, this patient has a progressive, somewhat chronic complaint and is now here for further evaluation, which is definitely appropriate. From what you mentioned, the patient had really, it was all pertinent negatives on exam, which I think are important to know. From a hemodynamic standpoint, vitals were stable, normal O2 saturation on ambient air, and as I just mentioned, pretty unremarkable exam. And I think one important thing, just given the opacity, is it seems like there's a lack of infectious symptoms. So he has this X-ray coming in prior to ED evaluation. So I think probably at this point, could you get a chest X-ray and just get a PA in lateral? Because we know we have an ill-defined opacity, and the lateral can help us identify the location a bit further, help out look for pleural effusions. But I'm sure, as you mentioned, and we'll probably get to getting a chest CT is going to be in the algorithm as well. And I think one important thing I wanted to point out, and then would love to hear Mira's thoughts, but I think in with this opacity, a lot of people can equate that to pneumonia, but we know that it can be more complicated than that, and pneumonia is a clinical diagnosis. And from what you've told me so far, that seems to be less likely. But Myrna, I'd love to hear you talk a little bit more about your approach to pulmonary opacity on a chest x-ray in a patient such as ours today with chronic pulmonary complaints who is overall well appearing.
Sure, I'd love to. So, an opacity is it's really a catch-all radiographic term, and we use this to describe an area of the lung where the amount of air in that area is decreased relative to normal parts of the lung. Opacities appear less black, so gray or white, than the surrounding air-filled tissue. And we really broadly categorize opacities as two big buckets: interstitial or airspace opacities. Then we look for clues, shapes, patterns, distribution, associated features, and we use these clues to better characterize the opacity. For example, for interstitial opacities, if we have the presence of linear, reticular, or nodular patterns, this may suggest an inflammatory, fibrotic, or lymphangitic process. While evidence of septal thickening, vascular congestion, and pleural effusion might favor pulmonary edema. Now, switching gears to what our patient has when we're talking about airspace opacities, dense opacification with obliteration of the underlying bronchovascular structures and associated air bronchograms can suggest consolidation. But as you pointed out, our patient was really non toxic appearing, so this didn't seem to fit. So we think about other types of airspace opacities, like those due to atelectasis or collapse, where we can see clues of volume loss, displaced fissures, elevated ipsilateral diaphragm, or displacement of mediastinal structures. And our patient had this airspace opacity. It was really ill defined and incompletely characterized by chest x ray. So then we start to think, well, how can we get a better image into the lungs? And CT scans, advanced images like that, can really provide higher attenuation images and cross sectional imaging, which can eliminate this challenge we have with 2D chest x rays, where we have a lot of superimposition of structures and it's hard to tell finer detail. In addition to better characterizing the opacity, CT scanning also can provide information about other chest structures that might give us further clues into the case.
Thanks so much, Myrna, for walking through that. I really love that framework of talking about x-rays. When I teach x-rays to like the new interns who are doing it, I really take three levels of interpretations. If you have no idea what's going on, just tell me literally what there's like black here, there's white in this area, looking a little hazy. I can see through it or not. And then you can put that together to the next stage, which is like, this is actually an interstitial alveolar opacity, sorry, interstitial or alveolar opacity has this reticular pattern. And then the third one is to say, okay, this pattern makes me think of pneumonia or pulmonary edema or something like that. And so I think taking it from the core building blocks is always the right way to approach these. And we'll post these images so you all can see what you think.
Awesome. Thank you both for providing that. Such a great framework. And if I remember, I feel like if I was an intern day one, I would have been like, this is black area, this is white area.
Exactly. Not wrong.
So there's progress for all of us. But yeah, thank you both so much for walking through that. And Sarah, I'd love for you just to reframe our case for those listening today and tell us about the next steps in diagnostic evaluation.
Sure. So we have a middle-aged man with a previous extensive cardiac history, including VFib arrest and AFib status post-ablations, who's presenting with acute on chronic shortness of breath, dyspnea on exertion, and pleuritic chest discomfort, with a new ill-defined opacity to the left upper lobe without any sort of infectious symptoms. And so while he was in the ER, I can go over some of his blood work as well. Majority of his blood work done in the ER was largely negative. His BMP was unremarkable. His CBC was all within normal limits, but some of the pertinent negatives, his troponin was negative. His BNP was 32. They did send a CRP, which was 1.7, and he also had a procalcent, which was 0.02. And they swabbed him for COVID, flu, and RSV, all of which were negative.
Thanks so much, Sarah. Yeah, these type of evaluations, I feel like sometimes you can look at this and be frustrated because it doesn't give you a diagnosis, right? There's not just a clear, white count's 25 and the procal is elevated, so I'm calling this pneumonia. But we always have to remember that pertinent negatives can be as helpful for our diagnostic process as the positives. We think about our negative likelihood ratio of something like a normal pro BNP, a normal procal. We'll have to do a whole episode on ProCal, but I do think that this is like the perfect type of patient in the ED. He's coming in with symptoms, pretty good data that they may not benefit from antibiotic treatment at least. And we can explore the data a little bit more. But we've talked about now, we still don't know where we are. We don't have a good hint of what this actually is. And so we've discussed previously just getting a CAT scan. And I think one thing is that it's always helpful to think about what you're looking for on imaging, and then you can protocolize your imaging the right way, right? It's not as easy as just saying, let's get a CT chest. We could do a high resolution ILD CT chest. We could do a CT chest with contrast. We could do a pulmonary angiogram, all of which are slightly different. Javier, I was hoping you could talk us through how you decide with a patient and our patient like this, what type of CT you'd order once you want to characterize things a little bit better.
It all depends primarily on the clinical presentation, obviously. Two main types of CTs that we as pulmonologists usually order. It's with and without contrast, basically. We usually use contrast when we're concerned with vascular diseases of the thorax, and that would include pulmonary vasculature, but also cardiac and central vasculature. And also when we are interested in the mediastinum, when we want to evaluate structures that are not vascular, for instance, lymph nodes. Contrast helps us distinguish between vessels and lymph nodes, and it's very useful in that scenario. Now, when we want to evaluate the parenchyma itself, in pulmonary medicine in general, we do not need contrast for diseases like interstitial lung disease that you mentioned, or lung nodules, emphysema, bronchiectasis, infections. There, contrast is really not necessary. For the patient who presents with chest pain and shortness of breath, although somewhat chronic, the possibility of pulmonary vascular disease, I think, would be an indication in this case for using contrast. Now, one of the keys in using contrast is when do you time the injection of contrast, et cetera, and that will depend on the indication. And that's more of a radiological kind of decision. What's very important here, I think, is to communicate what you're looking for very clearly to the radiologist. So it's very important to spell out your indication, what you're worried about, and sometimes even calling the radiology department to say that, to say what you're looking for, because they will time the injection of the contrast and the scanning depending on what you're looking for. So again, I think we should underline that the best way to get the right CT is to work in conjunction with radiologists by explaining exactly what you want.
Yeah, totally. I feel like just writing shortness of breath at indication is usually not as helpful. And as you mentioned, we have some suspicion for pulmonary vascular disease here, given the relatively normal findings you had so far. You also mentioned, Sarah, that new fat pad. That's an interesting thing to have all of a sudden have a new fat pad. We would try to characterize things like that a little bit better. What ended up happening? What did the patient get next?
So he ended up getting a CT chest or CTA chest, and I think the ED was initially looking for maybe a PE. And so it showed no acute PE, but it did show mild mosaic attenuation of the lungs, particularly to the left upper lobe, and some left upper lobe segmental atelectasis and volume loss. And it showed mild narrowing of the pulmonary arterial branch to the anterior left upper lobe, and interestingly, some narrowing of the left upper lobe bronchi. The reading radiologist noted that this could be due to maybe some scarring. They questioned maybe sequela of a prior infection, maybe inflammation, but they did note that it was new compared to scans that they had from 2 years ago.
Thanks so much, Sarah. Yeah, super interesting, right? I'm glad that this patient ended up getting contrast to look at both the look at the pulmonary vasculature more, just as Javier mentioned. I think we have some more characterization of the opacity that we saw, and Mirna had mentioned that earlier as well. And I hear the word, and I heard you say mosaic attenuation, and I think we hear that a lot. But Mirna, would love to hear when you're teaching learners and you're working with people on teams and you hear the term mosaic attenuation, what does that make you think of and how do you explain that further?
Yeah, thanks for asking. I know this sounds pulmonary nerdy, but this is mosaic attenuation is my favorite radiographic sign. And I think for our listeners, if you have a favorite radiographic sign, it might be a telltale indication that you should pursue a career in pulmonary medicine.
Yeah, yeah, that's what we're here for. Yeah.
We love chest CTs that look pretty to the eye. But so with mosaic attenuation, the lungs look like a sharply defined patchwork. And you have these adjacent patches of darker or blacker regions that are abutting areas or patches of lighter or grayer regions. Now, a common cause is parenchymal disease due to patchy ground glass opacities. And in these cases, the higher attenuation ground glass regions are actually the abnormal regions. And this is often caused by infections or inflammatory processes. Another cause for mosaic attenuation that we should consider is obstructive small airways disease. In this situation, the lower attenuation regions are actually the abnormal areas, and this is due to patchy air trapping from small airways obstruction and associated vasoconstriction. And finally, the third sort of bucket that we consider with mosaic attenuation, or in this case, mosaic perfusion, is with pulmonary vascular disease. And once again, the lower attenuation regions here are the abnormal patches, but here it's due to oligemia or reduced pulmonary blood flow from occlusive vascular disease such as chronic pulmonary emboli.
It's a great review. Thanks so much. Yeah, I love a good mosaic attenuation workup myself. So this scan is notable for a couple of things. It has that mosaic attenuation, it has a little bit of opacity, and then it's notable for this PA and left upper lobe bronchi narrowing with some possible scarring, which is a pretty interesting finding that's new from 2 years ago that we heard. We recently had it on case files a case of fibrosing mediastinitis that presented similar to this. And so I'm thinking about something like that, although this is a prime example of recall bias since Christine and I just heard about it 2 or 3 weeks ago. And so it's on my mind. And we had learned in that episode that we'd be looking for inflammation and fibrotic changes that cross fat planes in fibrosing mediastinitis. And we don't have a mention of that here. So who knows, maybe less on the list. We also know that it's probably not congenital, given it's new from 2 years ago. The patient hasn't had it forever. But that's just two things out of a list of many. So Javier, are there things that you think of when you're thinking about patients with focal bronchial narrowing, that you see on a CAT scan like this?
The first thing I usually think about is cancer, but that's also a recall bias or practice bias
Yeah.
because that's what I usually deal with. But there's a list of other causes, obviously, infections like TB, fungal infections, inflammatory diseases such as sarcoidosis, granulomatosis with polyangiitis, relapsing polychondritis, amyloidosis, post-surgical and lung transplant is pretty common to have a narrowing of the bronchi. And traumatic, if you have bronchial injury, you can have that too. Foreign body aspirations, obviously. So there's a whole list of them. Obviously, the presentation leads you to one or the other. I'll admit that in this case, that wasn't a sign that we focused on at this point yet with the CT scan.
Thanks so much, Javier. Yes, and such a kind of a great review of potential causes for bronchial narrowing aside from malignancy, which I think a lot of us will always consider. Yeah, but interested, Sarah, what were the next steps that happened for the patient?
Yes, we ended up we were talking in the fellows doc room, and Dr. Zulueta recommended we call the thoracic radiologist. So we called the radiologist to discuss the case with him, and he pretty quickly had some more insight for us. So he immediately noticed that the left upper lobe vein was actually missing, and he ended up being able to diagnose the patient with a left upper pulmonary vein occlusion and an associated parenchymal infarct. There was volume loss and also vascular congestion. And he told us that the timing of the contrast that he had received was not, a usual ideal for diagnosing a pulmonary vein stenosis. But he said that he was really suspicious for this condition because on the scan he was able to see the other three pulmonary veins. And so he mentioned typically, if you are ever worried about diagnosing like pulmonary stenosis or occlusion, they would do an EKG gated CT. But it was the visualization of the other three low veins that clued him in.
I would like to add to that, and regarding my previous comment, first of all, how useful it is to call the radiologist. I love to do it when we're rounding, to sit down, put the speakerphone on, and we have very collaborative radiologists who are willing to, and you can set up a clinical session right there on the spot. And not only it's educational, in this case, it was diagnostic. He picked up the diagnosis basically. But before our encounter with this patient, pulmonary vein occlusion was not on our list, obviously, for bronchial narrowing, for pulmonary artery narrowing, or anything else. But the thoracic radiologist believes that there was pulmonary venous infarction because of that occlusion, and that caused scarring. It caused increased pressure in the lobe. That's why we have higher attenuation, and that probably was the cause of that narrowing of the bronchus and the pulmonary artery.
Wow, thanks so much, Javi and Sarah, for providing that. And Definitely not anything that I was thinking of, or had on my initial, differential as well, and love the fact of going, and talking with the radiologist, right? I feel like I love field trips and either going down to the lab to look at smears or even going down to the radiology department and sitting side by side so you can see what they're looking at. So I love that y'all did that, and that I think really helped with the case and the diagnosis as well. So Sarah, I know that pulmonary vein stenosis, as we just mentioned, wasn't really common on our differential. We may not know much about it, but I'm sure that you did a lot of learning while caring for this patient. And we're just wondering if you could tell us a little bit more about pulmonary vein stenosis.
So it can be common in children, although typically when that's present, it's more of a congenital issue. And then when we see it in adults, it can be from different things, particularly inflammatory conditions like sarcoidosis or a fibrosing mediastinitis, also sometimes malignancies. But I would think that more nowadays, we also can commonly see it after the pulmonary vein isolation or ablations, radiation therapy, and also, I think we mentioned earlier, some procedures and surgeries like lobectomy or a lung transplant. For our patient, he underwent pulmonary vein isolation for his AFib ablation. And this is one of the common ablation therapies. And during the procedure, the areas around the pulmonary veins undergo ablation, and pulmonary vein stenosis is a known complication, but it's fairly rare from the procedure. And symptoms with pulmonary vein stenosis can be very nonspecific. So common symptoms are cough, dyspnea, recurrent infections, and sometimes even hemoptysis. And I think interestingly for our patient, he had some of these nonspecific symptoms, but no findings on the chest x-ray initially. So I think it's important to also obtain a thorough lifetime procedure history and also have a high index of suspicion because you can have complications and symptoms prior to having imaging findings, which seems like it was likely the parenchymal infarct, which is what caused the imaging findings. But he did have symptoms for about a year prior.
Yeah. Yeah, thanks for that helpful review. I think we often gloss over things in the past medical history, especially things where we're less familiar with, like maybe you haven't had patients who've had a pulmonary vein isolation or ablation before. And then sometimes the time course can be really helpful. If like we know 2 years ago he had normal imaging and his symptoms started a year ago, it's something happened in between and it could be iatrogenic, certainly. I have a pulmonary vascular disease clinic, so sometimes these patients end up in my purview. Very rarely does this cause pulmonary hypertension, usually in kids, and usually if multiple pulmonary veins are involved, but every once in a while, and so they may end up seeing somebody like me. I think we also always just want to confirm, the radiologist said EKG gated CT can help confirm this. We also sometimes look for sort of functional imaging to see how stenosed the pulmonary veins are. An echocardiogram, and to Javier's point, talking to them before they do the echocardiogram about this is what I'm looking for. So they really try to visualize all of the pulmonary veins. Certainly cardiac MRI gives us a ton of detail now. And if we especially put in the indication, then we can make sure that we're imaging those appropriately. And then interestingly, I'll just point out that VQ scan, while we may not think of it as a diagnostic test for this type of injury or this type of condition, it actually can be helpful because we get backup of the tracer that goes in for perfusion in the area where we get pulmonary vein stenosis. And so it can actually show this really focal mismatch that we have there between the ventilation and perfusion in that area because of the venous congestion. And so it keeps on our mind if you don't have a PE and you don't have evidence of chronic thromboembolic disease, but you do have this one focal area that may be a pulmonary venous condition. Sarah, did your patient end up getting any of these other tests to confirm and corroborate what we had already suspected at this point?
Yes. After we talked with the radiologist, we placed a call to the cardiology team, and they were also surprised based on the CT findings. And after we talked with them, they were in agreement that he needed an echo. And so he underwent a TEE with the cardiology team. Um, and so I can read those results to you. The echo showed a left superior and inferior pulmonary veins arising from the common antrum, and the left inferior pulmonary vein with normal velocities, no obstruction. But to the left superior vein, pulmonary vein, it showed soft echo densities with near complete occlusion and trickle flow as seen by color Doppler. And then the right superior and inferior pulmonary veins were draining without obstruction.
It seems diagnostic testing has somewhat solidified our diagnosis for this patient. But Myrna, what do we do for treatment in this case? Do we have enough information? Do we need further testing? How would you proceed going forward with the patient?
Oh, yeah, no, I think we all learned so much from this case, and the workup and the collaborative approach from pulmonary, radiology, and cardiology really did provide us with enough information to take a treatment plan forward. So, this type of pulmonary vein stenosis or acquired pulmonary vein stenosis from catheter ablation can really lead to debilitating symptoms like we see in our patient. Unfortunately, we really have a lack of randomized controlled trials or consensus expert statements to designate clear indications for who should have treatment. But over time, there has been many reports from the cardiology literature giving guidance in these areas. And generally, what we see is that treatment should be offered to patients who are symptomatic with severe stenosis or to those who have multiple compromised veins. Asymptomatic patients should be evaluated as well for treatment, but this is more so done on a case by case basis. And when interventions are planned, this is more in the hope of preventing possible longer term complications. So, at present, pulmonary vein stenting is considered first line treatment for this condition, and stenting an occluded vein can provide therapeutic relief, but can also potentially prevent further infarction or chronic pulmonary venous hypertension. It's important to keep in mind that these stents are not infallible. Restenosis is possible, but from what we see in the cardiology literature, this is a lot less common than it was before. And things that may predict restenosis now, larger stents are being used, and having an understanding of the normal portion of the vessel as a predictor for which may stenose and which may not. I think we still need more randomized controlled trials to better understand patient selection, to better understand the optimal role of other interventions like balloon venoplasty, and to really clarify the type and course of post procedure antithrombotics, and also the timing and duration of post procedure surveillance strategies. Now, overall, in this case, this patient was discharged from the hospital and subsequently underwent angioplasty with stent placement. And really remarkably, the patient reported an immediate improvement in symptoms right after the procedure. Certainly, really a relief for him and just so rewarding, I think, for the medical teams. After the stent, he had a repeat TEE, which demonstrated adequate flow from the left upper pulmonary vein into the left atrium, and repeat imaging revealed resolution of the left upper lobe consolidation and ground glass attenuation. Dr. Zulueta might want to comment on this himself, but he saw the patient in pulmonary follow up where the patient reported sustained symptom improvement, including resolved chest pain, resolved dyspnea, and really amazingly, the ability to complete over an hour of exercise without shortness of breath.
Yeah, I would just underline that it was remarkable how he described the immediate response, the immediate improvement. When he got to his back to his room, he said the pressure is gone.
It's unbelievable. Yeah, you gotta love a case like that where you see something normal, you do something, the patient gets better, all the imaging gets better. Not always the case in our field, so that's great to hear. Well, this is a really great case. I'm so excited that you guys got to share it with us today on our Fellows Case File series. And we really thank you for joining us. We love building this network. We love hearing from people who have interesting cases and going to different programs around the country. So we'd love to hear a little bit more about Mount Sinai Morningside West and what it's like to practice there, what you like about it, and why it's been a valuable residency and fellowship experience. Sara, maybe we start with you.
Sure. So now as a third year and about to start on as chief, I've really loved this program. I think New York is a wonderful place to practice, and it's been a lot of fun being here. We have a lot of great colleagues, and but I would say I think like my favorite part is really like my co-residents and the people that make up the residency program. We have such a great group of people, and it's just such a nice like collegial environment. And obviously I've enjoyed it since I'm staying on for chief, which I'm really excited about. But despite how big of a program, I feel like I know everyone. So we're very lucky to have such a great group of people.
That's great. They're lucky to have you on as a chief. And yeah, I agree. Practicing medicine in New York is its own animal. A great beast. I think a great experience. Myrna?
Yeah, I know. I've been at this institution since I graduated fellowship, and to steal a phrase from one of my colleagues, I'll probably be clinging to the bricks of this building when the demolition wall comes through. I have a great commute. I live across the park, but also it is just the best place to work. We work with just a really dynamic community, many of them from marginalized groups. And our faculty are equally diverse, lots of diversity of our backgrounds, our clinical expertise, our research interests. It's just a really wonderful mix of high level academics, but also a really just collaborative, warm family environment. For the fellowship program, I can't talk enough about it, but what I'm most proud of is that we are incredibly intentional about holistically recruiting our fellows and ensuring that they come from diverse backgrounds, have diverse skill sets and interests, and making sure that they're going to come here and thrive in the nurturing and very academic environment that we provide. So we're just really lucky to work with our fellows and to work with amazing residents like Sarah.
That's awesome. Javier?
It's tough to follow that. I second everything that we've done. I actually just joined Morningside 3 years ago, and I came from working in Europe for many years. And my experience has been amazing, and mainly because of what Sarah said, people, the people that you work with, fellows, house staff, colleagues, it's just extraordinary. And as we saw with this case, we're learning with every single case, and at the same time, we're providing, I think, incredible service to underserved populations in the area that are really benefiting from top-notch academic medicine. So I really enjoy it.
Oh, I love that. I mean, I think just the 3 of y'all coming to this case today, I think has been amazing, right? We have the division chief for pulmonary, we have a PD leadership, as well, and we have an amazing house staff. So I think that y'all just displayed that, and thank you so much for sharing more about your program.
Yeah, and we finally like to wrap up each of these with a takeaway point. So mine is going to be Javier's. We've said it before on the show, we'll say it again, but call the radiologist, call the pathologist, call the surgeon. I could absolutely see this case going down the route of bronchoscopy, atypical infection, and literally all it took was a phone call to then have your diagnosis. And so it can always be very humbling. And I wish we just had this on every patient automatically, but definitely pick up the phone and make a call. Christina, things you're going to take away?
Yeah, I mean, I think just adding someone with a prior ablation, just having pulmonary vein stenosis on my differential now, so I wasn't really thinking about that coming in. So I think that's the main one. I guess the second one though is now after Mirna said it, I feel like I need to come up with my favorite radiographic sign. So homework for me to do for next time.
Yeah, we'll open with that for the next episode.
Yeah.
Javier, something to take away?
Yes. In addition to what Christina just mentioned, I'm adding pulmonary vein stenosis to my list. I want to share an anecdote which really highlights my takeaway point here. We were called for this consultation on a Friday afternoon. And as we were walking to the patient's room, Sarah, myself, and the rest of the team, we bumped into the primary team, and we joked with them. Oh, you're asking for a Friday afternoon consultation, the typical. And we went ahead. We did it. We saw the patient. We went to the fellows room, as Sarah said. We called the radiologist. And at the end, on Monday, I went back to the primary team and I told them, hey, the joke is on me. This was the most amazing consultation I have seen in many years. So thank you. You really have an opportunity to learn incredibly and to teach with every single case. Really, truly amazing.
Yeah, I love that. And keeping that in mind as you're fielding your many consults is always an important lesson. Sarah, something you learned?
Yeah, I think I would say when I first saw this with Dr. Zulueta on pulm consults, I think as a resident, my initial takeaway was like, not all opacities are pneumonia, and remembering the importance of like good history. And I think now as like a future fellow one day, keeping in mind pulmonary vein stenosis as a differential, and then not being afraid to call the radiologist, I think will be important.
That's great. And Mirna, we'll end with you.
Thanks. I think this case is such a great example about how bringing together different perspectives from different expertise for these tough collaborative cases really only benefited the patient and benefited our understanding of the case. Never be afraid to ask for help. I think we don't have to work through every single complex case on our own. There's really no pride lost in reaching out to co consultants and other colleagues to help bring new perspectives to each case.
Yeah, you could even listen to a podcast about it. Thank you all again for going on. Thank you all for listening. And make sure you tune in 2 weeks for our next episode. This case was written, produced, edited by myself and Christina Montemayor, and the music's original music by Eric Rogers. And we'll see you next time.